So I want to thank CurePSP and for everybody for coming out here today. I think this is a wonderful opportunity to learn and to exchange and to kind of build even further in community. I certainly learned a lot from the last two speakers, and I find the research and everything fascinating and really exciting that it's moving forward. I think getting together face-to-face really does make a big difference so people can talk and exchange ideas. While we're getting my slides loaded here, my name is John Stoffel. I'm a urologist at the University of Michigan. I'm a neurourologist, and so my practice really involves helping people with neurologic conditions help manage their bladder symptoms, both from a safety and a quality of life standpoint. I see a lot of people with a lot of different types of conditions, and a big part of my practice is actually Parkinson's, MSA, and atypical Parkinson's. And so what we're going to talk about here today are really some practical strategies about how to manage your bladder, to think a little bit about how the bladder works and a little bit about what is the tests that we use to be able to diagnose the issues that are bothersome to you, and then some broad strategies. I think I'm envious as the previous speakers have a lot of hard targets and things that they're looking at specifically to be able to help treat these underlying conditions. From a urology standpoint, we're more managing the symptoms. We're really trying to develop a system to help mitigate the way the bladder is responding to some of these neurologic changes. And so once we get the slides up, we can get going. Well, we can talk very broadly, can kind of get started a little bit about just a little bit about the way to think about your bladder. I mean, I think that the bladder is an organ that really just has two jobs. It's to store urine and to empty urine. I think the challenge of it is really how does that be regulated and how does that respond into everyday situations. I think that the bladder works best when you're not really thinking about it. And so it seems like a little funny statement, but I put it in a different analogy. So if you think about your breathing, if I tell you think about your breathing for the next 5 minutes, everybody's going to have difficulty with breathing. It's the same thing that happens with your bladder. So your bladder works best when it's following a pattern and it's running in the back of your brain. And that's some of the things that we're going to talk a little bit about here today as to how to best program that. Okay, so this is some of my information. These are my disclosures, and again, I would echo what was said before earlier is, being active, participating in some of these trials and looking forward to advancing the field, I think it really helps us all. And you may not individually get the benefit, but developing and moving the field forward is really what helps us all. And I would echo the statements about the NIH. So let's talk about our goals for today. So we want to talk first about why. Understanding about the bladder-brain connection, about why are we having problems with the bladder in these atypical Parkinson and Parkinsonian's conditions. I want to talk about with a little bit of what, like how do we diagnose this? And if you're going to go see a urologist, what would be some of the tools that we would talk about and how would we be able to help you with some of the different tests and different strategies? And then finally, maybe the most important is how. What can we do to help? And it's probably a lot more than you think it is. So let's just start with some early definitions here. So what I'm going to be talking about a lot here today is what's broadly called overactive bladder. You've probably seen many TV commercials about it, but really what it is that it can be described as urgency, difficulty delaying urination, and its frequency also can be accompanied with some getting up at night called nocturia. And this is really just a clinical description of symptoms. I think that when it's attached to a neurologic condition, that's when we say somebody has neurogenic overactive bladder, or it can broadly describe, you've also probably heard the term neurogenic bladder. All that really means is that urinary symptoms are being attached to likely caused by an underlying neurologic condition. And so what we try to do a little bit is just on definitions is differentiate between what's going on. And so overactive bladder versus stress incontinence is an important differentiation. So in overactive bladder, what we tend to see is that this is what's called an uninhibited bladder contraction, or the bladder is squeezing and emptying urine. And this is, people say, I can't delay urination, I just feel like I need to go, or I have an urgency to get to the bathroom very quickly. And it's unpredictable. It can come on just like that, and it's not seemed like it's being triggered by anything predictable all the time. Stress incontinence is a little bit different, and that's the loss of sphincter strength in the urethra. And that's usually, it's predictable. It's where you leak when you have coughing, laughing, sneezing. There's not necessarily urgency, and it's a much more kind of manageable, predictable state. Most of this, if you're trying to describe it in pictures now, this would be the I have to hold it and go to the bathroom, or a stress incontinence, you have some leakage when you're standing or getting up. Most of the conditions we see with Parkinsonism or other atypical conditions is overactive bladder, and it has to do with more the bladder and the brain connection. And so, broadly speaking, of all the different Parkinsonian conditions, including MSA, PSP, about 60% of people have overactive bladder symptoms. And it's mixed between this urgency, can't get to the bathroom in time, frequency, going to the bathroom very often, and then urgent continence where the leakage is actually coming out. And so urinary retention, true urinary retention where people can't pee, is relatively rare. It does occur, but many times it's coupled with other things. For example, constipation can cause urinary retention. In men, an enlarged prostate adds on top of this and also can cause urinary retention. Sometimes medications can, but the pure neurologic urinary retention where the bladder loses all power is relatively uncommon. Worth talking a little bit about sleep because this is something that affects people tremendously. Getting up at night, or called nocturia, is very common across these conditions, and somewhere north of 50% of people report it. This is maybe actually more due to the sleep-wake cycle in the brain being affected. And so when people feel like they're being bothered by getting up at night, they just can't sleep, they're going up, getting up a lot, this actually could be more dealing with the sleep-wake cycle than actual problems with the bladder. I try and differentiate this a little bit about what's bothering people the most, and if it's purely nocturia or getting up at night, I try to partner with our neurology colleagues to see if we can adjust medications to work on that first. There are some medications mentioned before that can target overnight urinary symptoms, but many times fixing the sleep-wake cycle or modifying it a little bit better actually has a much better effect than adding additional medications. It's a very active area of research. Michael J. Fox Foundation is trying to study this and get a little bit better understanding of the differentiation between it, but it is an important point to bring up. And so, touching briefly on MSA, MSA tends to have a little bit more severe urinary symptoms. And it tends to make it a little bit harder to empty and also has the same frequency, difficulty storing urine. I think what's a little bit different about it is so when people have measurements of an ultrasound, there's usually urine left in the bladder. And we don't really quite understand that very well, but it is a differentiating point between other types of Parkinsonian conditions. One of the main things also is it progresses a little bit more rapidly. And so if you're trying to just draw a broad differentiation between, if you say, typical Parkinson's and MSA, MSA tends to have urinary symptoms be some of the first things that present. So people get frequency, urgency. The time of onset is also fairly quick for urinary symptoms. It's less than 2 years, where it tends to be later in typical Parkinson's. Overactive bladder is very, very common. And as I mentioned, there's a little bit of an elevated post-void residual. And so I think maybe the main take-home point here to start thinking about is these urinary symptoms are occurring not because the bladder is particularly altered, but really it's because the brain and the bladder are not communicating as well as they should. So the bladder is not getting the right instructions. And so that's going to kind of be the crux of what we want to talk about moving forward is how do we build that better connection between the bladder and the brain? And so a very broad, and apology to my neurology colleagues here, probably wincing at my diagrams, but bladder has 2 jobs. It's to store and to empty urine. And so when you think about when the bladder fills up, there are sensory nerves in the pelvis that carry this information to the very base of your spine near your tailbone. That's then carried up to the brain, and then the brain is processing this information. Most of the time, the bladder is just turned on into a storage program, which the sympathetic nervous system is turned on. But when the brain feels that it's appropriate for you to urinate, then the parasympathetic nervous system is turned on, the bladder empties, and the whole thing resets. And so really, the bladder is most of the time sitting in a storage position. Your brain is kind of filtering it and trying to determine when exactly is appropriate. So how does it do that? It's running it through this complex network in your brain of all the different parts in your cortex, and it's trying to attach social significance to it, levels of stress, what else you have to do, social context. And that's the bladder is constantly filling up, and the brain is interpreting it within how you are in time and space. And then when it's appropriate level, okay to go to the bathroom, then you can get a message to get and go. So what we think is happening with the bladder in a lot of neurologic conditions, particularly in things like MSA or Parkinsonian conditions, is that the brain is just not filtering it the same way. And so you're not able to attach the social context of why they'll be able to suppress that urge to go to the bathroom is because the bladder's not being locked in the storage position. What's happening is that there's an emergency pathway that the bladder hits a threshold, boom, it activates the emptying program, and you have to go right now. And so what we try to do a lot is to rebuild this pathway so the brain becomes more efficient in hearing the signals from the bladder. We don't have a true medication that kind of wakes the brain up, but we can use strategies to be able to kind of work on the underlying pathways and strengthen them. And so when you see a urologist, there's different tools that we use. I think one of the strongest ones that you can do at home, is actually avoiding diarrhea. It's very simple, but you just track the symptoms, how much fluid you drink, how many times you go to the bathroom, at what time during the day, and it really helps us understand like when and what type of symptoms that you're having. It also helps you track some volume intake, and this is just a rough sample of one. What's really helpful for me when I see people, we can look and say, well, you have a lot of symptoms in the morning, and you look and you say, well, the 64 ounces of coffee probably weren't helping at that. The same thing you can say at night if you feel like your symptoms are very severe and you recognize, well, I drink a lot of my fluid intake for medications before I go to bed. And so it's a really helpful tool to be able to start marching out, figuring out when the symptoms occur, and really kind of what volumes are associated with it. If you come for symptoms that are really unclear, and so sometimes it's really hard for us to figure out when we're talking about what type of symptoms that you're having and what's the triggers for it, we can do some testing in the office, and this is what's called urodynamic testing. And what it is that we put a catheter in the bladder, and we fill the bladder very slowly with some fluid, and we can measure the pressures in the bladder. So we can track what volumes are causing what changes in the bladder from a physiologic standpoint. It's kind of roughly about taking a movie of the way the bladder works. Acknowledging this is a movie in public with a catheter in your bladder, so it's not maybe a true representation of how the bladder works, but it gives us actually a pretty good measurement of how your bladder works and what some of the provocative things that can occur. This looks a little bit like a weather pattern, but what we can see is on the vertical axis is pressure, and on the horizontal axis is time. And in this here, what we're seeing, and this was somebody with MSA, is that we see as the bladder fills up, they're having high changes in pressure, which are causing frequency and urgency. And so this is a sign that this person has very severe overactive bladder at relatively low volumes. And it helps, again, us understand what are the triggers for causing some of these symptoms. Important to say that you can still have these symptoms with having a negative study with urodynamics. And so the study is really more to tell about severity, not necessarily always to tell somebody if they have or they don't have a condition. It's really more of a tool to be able to understand what treatments we can work for people with. And so very quickly, I think it's also helpful to talk a little bit about questionnaires. Everybody uses questionnaires. I think people are sick of questionnaires. You get them on your phone from random things, and so we're all kind of questionnaire fatigued. But I think when you're tracking symptoms, it's super helpful, particularly for what I do in urology, is because I can tell the severity of the symptoms, the different domains, what's bothering you the most. I can kind of identify what treatments you might be a good candidate for. And then most importantly, we can track this over time to kind of see how well you're doing or whether or not things are effective. Again, it's a little bit of questionnaire fatigue. Everybody gets it, but I think it's really important to be able to give. It's also encouraging to see progress that's being made sometimes when you may not be even being seen a dramatic result yourself. So let's talk now on this last part here a little bit about treatment. The treatments, again, are focused on improving the bladder-brain connection, and I think that's really where we want to spend our time. If we're thinking about two broad categories, there's really two big buckets we want to be looking at, and this is safety and quality of life. And so both of these things are going to add to the health and happiness of people. So in safety, what do we want to do? We want to protect against falls, and so we don't want urinary symptoms to be the reason why people are getting up at night and falling, getting to the bathroom. We want to reduce skin breakdown. We want to reduce ER visits, treatment specifically for urinary tract infections. From a quality of life standpoint, want satisfaction. You don't want everything you're doing during the day to be managing your bladder. And this has to do with managing your time and also being able to manage the resources to be able to enjoy other activities besides managing your bladder all day. And so the context of these different treatment ladders is really important to be thinking about what else is going on. And so when I see people, I try and put the management of the bladder in the context of what other treatments are being offered, what other obligations you have, and what resources that you have. And so we want to look at where in the natural history of the disease the person is, and kind of what are their goals for that moment. Want to look at what resources are available. It's no good offering a treatment. Some of these medications are not approved by insurance plans, and spending a huge amount of medications for a small amount of gain isn't worth your time. And then we want to look at how it impacts your other care plans and make sure things don't compete. And then they're additive. They can be all done together. And I think that helps build this safety and quality of life improvement. So a rough treatment ladder for these conditions are that we start with behavioral therapy for the milder symptoms, and then we work up to pharmacologic therapy. The third line is that we use onabotulism toxin to be able to help the symptoms, and neuromodulations. Really had some excellent talks about how they work in the brain. We have some that also can work on improving bladder-brain communication. And then for more advanced conditions, to talk about containment or using tubes or suprapubic tubes to be able to kind of manage people. And so let's start first with behavioral therapy. Fluid management is super important. And this is what I tell people, is to be able to program your bladder to start being more predictable and the brain to recognize a pattern. So I usually recommend drink the same volume at the same time every day. It seems a little bit at odds, but I think you want a predictable filling of the bladder because the brain loves patterns from the bladder. You want to avoid being reactive, meaning that you're drinking only when you're thirsty, or you go long periods of being dehydrated and then drinking a lot. You want to drink the same volume at the same time every day, something for breakfast, mid-morning, lunch, and dinner. Try to avoid fluids after about 7, 8 at night to minimize getting up at night, if you can. What's a good target fluid intake? It depends on what you're doing, but about 32 to 64 ounces is a reasonable goal. There's nothing wrong with drinking more. It's just you're probably going to pee more if you drink more than 64 ounces a day. It's just physiologic. Also want to try to minimize irritants. So things like coffee, tea, alcohol, soda. You got to live your life, and so everything in moderation. But if you're drinking more of those symptoms are going to make the bladder both fill up very quickly, and they activate a lot of the sensory nerves, causing irritation. And what we want to do is put the bladder in a pattern where it's recognized predictable filling. Things that make it fill up very rapidly or cause irritation could ultimately drive worsening symptoms for you. So another thing I think is a really important benefit that has low risk, high benefit is actually physical therapy. Physical therapy helps strengthen the pelvic floor and helps the voluntary relaxing, and it helps, again, kind of potentiate these pathways between the pelvic floor and the brain. Usually we do this through a pelvic floor physical therapist, and so you get a referral for it. But what they do is they'll work with you about identifying the muscle groups that need strengthening. I could get you started here on the easiest exercise that we start people with is squeeze the muscle of your rectum, like you're stopping passing gas or trying to hold in diarrhea. Hold it for a count of 5, and then relax for a count of 10. That's what's called a Kegel exercise, and that's one of the foundational exercises that we use for pelvic floor therapy. This can be very effective in helping people, again, get a little bit better control. There's been some data on this. This was 43 people with Parkinson's, and this included both typical and atypical. And this was randomized into behavioral therapy versus control. And ultimately, what we saw is about a 50% improvement in symptoms overall, and when compared to a control, is about a 20% difference between the two. And so not a cure-all, but every little bit is additive. And so this is an easy thing to do without medications and also is sustainable over time. Medication is the next line of therapy, and good to kind of know a little bit about where some of these targets are. So if you're looking at your bladder, basically the storage and emptying your bladder is focused within what's called the detrusor muscle, and this is the muscle that both relaxes and squeezes. And there's two separate receptors. There's the muscarinic and the beta-3 adrenergic ones. The beta-3 agonist ones are from the sympathetic nervous system, like we talked before, and that helps drive bladder relaxation. The muscarinic ones are the ones that cause contraction of the bladder, kind of broadly speaking. And so the medications we use for for overactive bladder target these two different systems, and they work in different ways. So the anticholinergics are the older medications that have been around for many years. There's been some good studies looking at particularly Parkinson's. When I say Parkinson's, I talk about broad Parkinsonian as opposed to just a specific type. And the anticholinergics here do show improved storage of the bladder. They decrease frequency and urgency, urgent continence, but particularly there is some question about whether or not they could change cognition. Anticholinergic medications have other side effects. They can slow down your bowels, they can cause a little confusion, make your eyes dry. And so particularly in something like Parkinsonism, where you may have lower amounts of acetylcholine, these medications, it's a concern, may amplify some of the side effects. So they are effective, and unfortunately, many times they're the first choice for insurance companies, but they got to be concerned about side effects. If you look at, here's a meta-analysis where they pooled all the data together from multiple different studies, and davoids, incontinence, getting up at night, all of them favor the medication, this anticholinergic medication, so it's effective. I think, again, the side effects are the concerning thing. And the take-home would be is that many times these medications have shown to have a greater than 50% improvement compared to a placebo. Important part of these medications, they don't actually fix the problem. They just treat the symptoms. So you have to take the medication every day. If you stop it, the symptoms do come back. And so people have heard a lot about dementia and these medications called anticholinergics. And this came from a study in 2018 in the National Health System in England. They looked at a cohort of people, and they found that a group of people with dementia were more likely to have been on these medications, these anticholinergic medications. It's not causal. It doesn't say these medications cause it, but there was an association with these medications and dementia. And kind of roughly, if you kind of just attach some numbers to it, is that people who had been on these types of medications for more than 3 years had a stronger association than not. Again, it doesn't necessarily mean that we stop giving these medications for the bladder, but all these things would kind of take into account of what we can do to minimize risk for people and to target benefit. The other class is the beta-3 agonist, and this relaxes the sympathetic nervous system. There's less data on this because they haven't been around for as long, but they also show good efficacy. I think that the beta-3 agonists, when we look at from a urology standpoint, maybe take a little bit longer to work. We haven't seen as much as the immediate effect as we have, and that can be frustrating for people, but usually by about 2 to 4 weeks, we tend to see a benefit for this. Again, looking at something like a meta-analysis, again, shows when pooling the data, it does show benefit, maybe not as strong as effect as the anticholinergics, but I read this more as there's just less data available for it. Again, I would say that they're effective in decreasing the overactive bladder symptoms compared to the placebo. When I compare the two, using anticholinergics for beta-3 agonists, I would prefer to use the beta-3 agonists. One of the side effects of these beta-3 agonists is that they can elevate your blood pressure. Sometimes they can be very helpful in some of the conditions that cause orthostatic hypotension. So you can maybe actually get a little benefit from some of these medications with your blood pressure. Anticholinergics, we mentioned dry mouth, constipation, and confusion. And so do tend to favor the beta-3 agonists, but unfortunately we're limited somewhat by some of the insurance companies that contract with some of the companies. Good to ask if you're being prescribed an overactive bladder medication, what type of medication it is, and then go over the risks and benefits with the prescribing physician. So if medications aren't effective, or if the medications, you have a short trial that you wanted to move to something else, there's been great data to show overall in neurogenic bladder that people respond to Botox or botulism toxin injections of the bladder. So this is an office-based procedure. We look in the bladder with a little camera and we inject this medicine directly into the bladder, and it blocks the release of acetylcholine from making the bladder contract. And so it's blocking a lot of these aberrant signals for the bladder to contract. It takes about 1 week for it to work, and it lasts about 6 to 12 months. The downside of it is that we don't know who's going to have a great response, who's going to have a moderate response, and who's going to have a minimal response. Sometimes, if we have a great response from it, we can lose contractility of the bladder, and about 15% of people in general can be unable to urinate after this. So it could be high benefit, potentially a little bit of risk involved with it. When we look specifically at Parkinsonian conditions, data shows from a small trial, but data nonetheless, that showed that it lasts somewhere about 3 to 12 months in variable range for people, and 70% of people responded. So I took that as very encouraging, that I think very responsive to this treatment. About 12% did have to catheterize themselves because the bladder lost some contractility. So again, weighing a little bit of risks and benefits, it's a good discussion to have for options. So I'm also very excited about neuromodulation as another line. It was talked about in the previous talks, and this is really boosting the communication between the bladder and the brain. Unlike, I think, for direct treatment of trying to remodel the cells, what I think about this, and for the bladder treatments, it's really an amplifier. And so what you're just trying to do is carry the signal from the bladder to the brain so it recognizes it and is be able to use the patterns of storage and emptying that you want the bladder to be able to do. And so neuromodulation is stimulating the nerves down near the sacrum. And this is kind of the S3, specifically third sacral nerve root. And what this is doing is just amplifying the sensory information. It's not telling you to go pee, it's not stopping you don't use the device to stop urination, it's just something that's carrying the signal for it. And we've had not a lot of information about specifically in Parkinson's, but I think it's a very, very encouraging potential mechanism for treatment of this. What we do know is that right now there's 2 different systems we can use. One of them on the top is an implantable sacral nerve stimulator. And so that's done in the operating room. It's done 2 separate OR procedures. One of them put a test lead in to see if it works. And the second one, you can implant the fully working unit. And it's a very powerful device. The battery can last up to 7 to 10 years. You can turn it up, turn it down. We can try different types of programs for it. But it does require some type of operative procedure to be able to implant. There's an office-based one that uses the posterior tibial nerve, which joins into the sacral nerve, the target sacral nerve root. And we have more data on this. It's an office-based therapy. You come in, it's a 30-minute treatment. An acupuncture needle is placed next to your ankle bone, and it's stimulated for about 30 minutes, again, amplifying the sensory nerves. This we actually have decent data on to show that I think it can be very effective in some people. And data that we have roughly shows that it can decrease the amount of voids people have by 6 a day, decrease the incontinence episodes by 3. This is a slow-moving treatment, and so you usually don't see a benefit until after about 6 weeks. But after 12 weeks, when we've done weekly therapy for 12 weeks, people can come every other month or so, and we've had good durability of this. And this is some of the trials that we've been running at Michigan looking at the effectiveness of this also. Encouraging things are there's a trial that's recruiting for an implantable posterior tibial nerve stimulator for Parkinsonian's conditions, and again also moving field forward. This is a trial that will wait on some of the data for this, but an implantable device may have less morbidity than a sacral nerve stimulator. So exciting to see. So sometimes, depending on where things are in the disease progression, sometimes you just need to be able to contain the urine. And these are some of the strategies we'll go through here that just offer better protection, skin protection, and less concern about having to manage some sequelae of the symptoms. This is what's called a condom catheter. And what it is just a condom, plastic sheath that goes over, for the men, goes over the penis, and it drains into a bag. Many times this can be a useful tool for night people so they don't have to get up and go to the bathroom. Usually it's hard to wear all the time because it falls off or it can cause some irritation for it, but situationally it can be very helpful for some people. For women, there's something called a PureWick, and what this is that it's a device that is kind of placed between the labia and the gluteal folds, and it works as a suction device. And so similar to the condom catheter, it just collects and diverts the urine away from the skin. Again, very useful at night or when people have periods of immobility. There's not really a mobile one that's effective yet, but a PureWick can be very good to help people get a good night's sleep and so they don't have to get up at night. Indwelling catheters can also be helpful for some people. It's a relatively old technology. It was developed in the 1930s, and it's just a gravity drainage. What you're seeing here is a catheter. They have a balloon, put it into the bladder. The balloon inflates, and that keeps it from falling out. It's good to be able to measure how much urine comes out, good to be able to just contain and divert the urine, in particular if people have a hard time either getting to the bathroom or they're just not able, or if they're leaking continuously urine. Catheter does require some care, and so you need to keep the drainage bag below the level of the bladder. So can't walk around with it like a purse or like a backpack. Then it actually acts like a snorkel. Things go back into the bladder, and you don't want to do that. But you need to make sure that it drains continuously. Change the catheter about every 4 weeks, 4 to 6 weeks, and really important to hydrate because it can cause a risk of infections a little bit higher with this. And it's because bacterial colonization lives on the tube, and it can make it the urine gets concentrated, it can make it difficult to tell if you have an infection. The advice for people with catheters is don't screen for urinary tract infections. If you have a urinary tract infection, symptoms are getting worse rather than better, and then you check with a culture. The urine dipsticks do not tell us any information. They just tell us that there's bacteria in the urine, so we need a culture. So indwelling catheters, again, just a word that the pressure points for them are where people are sitting, particularly in men and also in women where there are points of pressure that can cause some damage to the urinary system. So finally, we'll talk about a suprapubic tube. That's another type of indwelling catheter. It's actually the same catheter as a urethral catheter, but it just goes in through the top of the bladder. It's usually placed either in the operating room or by a radiologist. It's a very short procedure, which a small hole is punctured in the top of the bladder and the catheter is put in place. Uses the same drainage bags as the other types of catheter. Also needs to be changed about every 4 to 6 weeks, but it's much easier to change for people. Many times you can just be sitting in a chair. You don't need to have much prep to do it. It may have less urinary tract infections too because it doesn't sit down near the rectum or by the vagina or in the groin, which can have a higher bacterial count. And so the key points here, to maybe take-home points, are that many of the urinary symptoms that can occur, there are many urinary symptoms that can occur, but overactive bladder, I think, is the most common and probably the most bothersome. And really conceptually, this is just because the bladder and the brain are not talking very well. And so the treatment goals, the overall arching goal of the treatment is just to make things more efficient with reproducibility, predictability, and to decrease kind of some of the variance that the bladder that the bladder can result in spasming with. I think there's new treatments that are exciting, particularly the neuromodulation, and I think we're getting better and better at being able to manage some of these symptoms. Catheter remains a good option for some people, but again, care is needed, and good discussion of benefits and risks for that. So again, I'd just like to say thank you. Thank you, everybody, for coming out and having the time and discussions to be able to talk about this. Thank you for the organizers, and thank you for allowing me to talk to you tonight.
Okay, everyone, I think we have time for 1, maybe 2 quick questions, if we have them. And Kelsey's got you.
Just 2 quick questions. One, what type of medication is Gemtesa?
Yeah.
What category?
Yeah, it's a beta-3 agonist.
Okay.
And so that's the one that turns on the sympathetic nervous system. So
Okay.
that not a lot of data on Gemtesa. It's other medication. The other medication in that class is Myrbetriq or Mirabegron. All the data I presented was for Myrbetriq, but we think Gemtesa is very similar.
Okay. And the other one is the I-trip procedure for like an enlarged prostate, if that maybe be the problem?
And so with men as they get older, your prostate gets bigger. And so didn't talk too much about this. Men with MSA, we try not to treat the prostate because if you open up the prostate, there's a much higher risk of incontinence because the sphincter muscle actually doesn't close quite as tight. People with atypical Parkinson's, we do actually try to treat or people with other variants of Parkinson's, we do try to treat the prostate a little bit more, particularly if they have outlet obstruction. The specific procedure you talk about is a new one, which it just kind of opens up the bladder neck for people, and we don't have much data on it, particularly with people with neurologic conditions yet. Okay? Thank you very much.
Thank you, Dr. Stoffel.